Terrific. Okay, so thanks. So the bill, as it is written, is called an act establishing Medicare for all in Massachusetts. And again, I want to thank Deborah Levinson for working with me on this slideshow to make sure that we got the most important parts of the bills covered in it. So to begin, the bill's sponsors are Jamie Aldridge in the Senate and Lindsay Sabadosa and Margaret. And I'm sorry, Margaret, your last name is covered up by people.
Scarsdale.
There we go. There she is, Margaret Scarsdale. Very grateful for our wonderful sponsors. And I believe at least close to 40 have signed on so far or getting up there in the for co-sponsors for the bill. You can find the links on the MassCare website, of course, if you want to read it either side, the Senate or the House bill. So the bill in a nutshell. It is hereby declared to be the policy of the Commonwealth to provide equitable access to quality, affordable healthcare services for all its residents as a right, responsive to the needs of the Commonwealth and its residents, without co-insurance, co-payments, or deductibles, and to be accountable to its citizens through the Massachusetts Healthcare Trust. So the trust, in other words, would replace our current mix of public and private health insurance plans with universal and comprehensive healthcare plan available to every Massachusetts residents. And the bill in a nutshell, this isn't what I wrote, this is what's at the beginning of the bill. So what will the trust do? The trust will guarantee high quality healthcare to all residents by 1, paying for all medically appropriate healthcare services performed by eligible practitioners or facilities chosen by the resident, and 2, funding capital investments to make sure that, whoops, sorry about that. I'm just trying to move the people so I can read this better, to make sure that all the people in the state have adequate healthcare facilities. So what's important to note here is that medically appropriate healthcare services, as defined by the bill, includes many services that are often not covered by public and private healthcare plans. So this will include dental care, behavioral health, sight, hearing, home health care, nursing home care, long-term care, and hospice care, as well as services promoting preventive health and encouraging better access to primary healthcare services. Also important to note for point 2 there, the funding the capital investments, is these would address the current inequalities to access to healthcare facilities in underserved parts of the state, and would also reduce unnecessary duplication of healthcare facilities in currently overserved areas. And I'm sure we're all very aware of which parts of the state are overserved and which are woefully underserved in terms of access to healthcare and healthcare facilities. Okay, so the operating budget of the trust will pay for the services rendered by physicians and other clinicians, budgets for institutional practitioners, and the administration of the trust. So what does this mean? Well, particularly for number 2, for budgets for institutional practitioners, like for example, a hospital. So a global budget would be one way to do that, and that would be a predetermined amount of money paid for an upcoming year based on data from the previous year, as well as expected changes in healthcare costs and trends in utilization of services, like population trends, whether an area is growing or shrinking in terms of population. And overpayments would be returned to the trust. That's one way to do it. Another way to budget for institutional practitioners would be a fee-for-service budget, which would pay individual care providers for services in a hospital. And the trust could decide to budget either way. The capital expenditures budget would pay for constructing or renovating health facilities and for major equipment purchases. This again would be addressing that inequality where some areas are very underserved in terms of what's available to them for their healthcare needs. I apologize, this one's a little hard to read. I meant to redo it and I ran out of time. I just wanted to give you a little idea of the healthcare trust organizational chart before we get into what the trust looks like and who's answerable to whom. This is a simple version. So first of all, we will have a board of trustees that will oversee the trust. We'll get into the details of that in a moment. The board of trustees would hire an executive director who would oversee the healthcare trust. The executive director would then hire directors of 5 different divisions that would oversee all of the practical matters of running the trust in the state. There would be a regional division, an administrative division, planning division, information technology division, and then quality assurance. And we'll get into what each of those are in just a moment. But this is basically what it's going to look like in terms of the organizational structure. Okay, first question. Well, who's going to be on this board of trustees that's going to oversee the trust? There will be 29 members, as the bill is written now. First of all, the Secretary of Health and Human Services, the Secretary of Administration and Finance, and the Commissioner of Public Health. Currently, that's these folks right here. Then there will be 8 trustees appointed by the governor. 3 of those will be nominated by organizations of healthcare professionals who deliver direct patient care. 1 nominated by a statewide organization of healthcare facilities. 1 nominated by an organization representing non-healthcare employers. 1 nominated by a disability rights organization. 1 nominated by an organization advocating for mental health care, and a healthcare economist. And then there will be 10 trustees appointed by the Attorney General, 2 nominated by statewide labor organizations, 2 nominated by statewide organizations that have advocated for single payer, 1 nominated by an organization representing senior citizens, 1 nominated by a statewide organization defending the rights of children, and 1 nominated by an organization providing legal services to low-income residents. Also on the trust, there will be an epidemiologist, an expert in racial disparities in healthcare, an expert in women's healthcare, and the last 2 experts are to be nominated by a statewide public health organization. And then finally, there will be 8 trustees from the public, from the general public, each appointed by one of the governor's counselors from their district. So that will comprise the 29 members of the healthcare trust. A little more detail. Of these 29 members, 1 will have professional, lived, or academic experience related to homelessness. 1 will be an expert or have professional, lived, or academic experience related to LGBTQIA+. And 1 will be an expert or have professional, lived, or academic experience related to patients' rights or advocacy. All right, so what is this board going to do? Number 1, the responsibility of the board is to ensure universal access to high-quality health care to all residents. Establish policy on medical issues, population-based public health issues, research priorities, scope of services, expanding access to care, and evaluation of the performance of the system. Also to evaluate proposals for innovations in health promotion, disease and injury prevention, health education and research, healthcare delivery. Establish criteria for evaluating requests by health facilities for capital improvements, and hire an executive director for the trust. Just a quick note, scope of services refers, for example, to defining what services can be performed by a particular licensed practitioner, and then which need to be referred to a specialist. There are provisions in the bill, by the way, just to know, for disclosing conflict of interest, since in all likelihood, there's going to be someone on the trust who has some connection to, for example, a healthcare vendor or some such. So that is written into the bill that conflict of interest has to be disclosed, and any person who has some sort of a conflict of interest will not be able to be involved in decision-making processes, such as a purchase that the trust wants to make or something. Okay, so they're to hire the executive director. The executive director has these. to establish the enrollment system for the trust, to seek all necessary waivers, exemptions, agreements, or legislation if needed, so that all current federal payments for healthcare will be paid directly to the trust. Negotiate price discounts for prescription drugs and medical equipment. Negotiate or establish rates of reimbursement for medical services. Develop the payment system for paying practitioners. Oversee the budget. Prepare an annual report, and also appoint directors for the 5 different divisions that we mentioned. Just to note, just a quick note about current federal health payments for healthcare, or federal payments for healthcare. That refers to Medicare, Medicaid, and other federal social insurance, such as CHIPS for child healthcare. The executive director would negotiate with the federal government for a waiver to have those funds that would be used to cover Massachusetts residents who are eligible for example, Medicare or Medicaid programs, and have that put into the trust. Just to note that an annual report that would be prepared by the executive director would be submitted to the governor, the president of the Senate, and the Speaker of the House, and be easily accessible to the public to keep that transparency. Okay, so now we're going to talk about the 5 different divisions. The executive director is to appoint or is to hire a director for each of these divisions. And here's what these different divisions will do and how they figure into getting people the healthcare in Massachusetts under this bill. So the regional division will oversee offices located throughout the state to implement a statewide education program to keep the public informed about all aspects of the healthcare trust. And the director of the regional division would also hold annual public meetings. The regional division director is also to hire a is to establish a professional advisory committee to provide expert advice to the director. But there is a requirement that at least 25% representation on that advisory committee has to be from the general public. And also the director is to establish a reasonable number of regional offices to share the public in consultation with the other divisions in order to implement a public education program that's really going to reach all the people. And each regional office will hold its own annual public hearings to ascertain any unmet needs. Okay, the next division, the administration division. This is the division that will make payments for covered services and seek reimbursement for non-covered services, will invest the trust fund assets, and develop the budgets for the trust. And the administrative division may also have a professional advisory committee, of which 25% would need to be from the general public. And note that the budgets that they're overseeing are for both operational and for capital budgets, for capital improvements in the state. Okay, the planning division, this is number 3. Planning division will coordinate healthcare resources and capital expenditures to make sure all eligible participants have reasonable access to covered services. As with other divisions, they can establish a professional advisory committee. And also the planning division is to provide an annual review of the adequacy of resources throughout the state. For example, the planning division would be in charge of overseeing recruitment of primary care physicians or dentists in underserved areas, and also evaluating the healthcare facilities and how adequately they serve their populations. And the planning division would then, if need be, make recommendations for capital improvements to the board. Next is the IT division. They'll develop an IT system that coordinates all medical and dental facilities, maintains confidential medical records, and develops a patient tracking system to monitor quality of care and preventive care guidelines. And an important thing to note, as this tends to be a concern with people, anyone in the public could choose to have any part of their medical record not be a part of the medical records that are computerized or that are digitized. Anyone can leave any part of their record out and have that just on paper instead. Okay, the Quality Assurance Division will support the establishment of best quality of care standards, including appropriate staffing levels, evidence-based clinical practices, elimination of medical errors, timely access to medical and dental care, integrated patient-centered care, and compassionate end-of-life care. And the director of the Quality Assurance Division will submit an annual report to the trust with recommendations for maintaining and improving the quality of care services to all residents. So those are our 5 divisions. Okay. Who is eligible to participate in this plan? All Massachusetts residents, including homeless individuals, individuals who are incarcerated in Massachusetts, and undocumented individuals will be eligible to participate in the healthcare trust. A resident must live in Massachusetts and demonstrate intent to continue living in Massachusetts if temporarily absent. And then the bill uses the Mass Health residency requirements in its language also. It provides that the trust is going to adopt standards and procedures for determining whether a person is a resident. Such rules will include a provision requiring that the person seeking resident status has the burden of proof in the determination, a provision that a residence established for the purpose of seeking health care shall not be by itself establish that a person is a resident of the Commonwealth, and specifically includes homeless individuals and incarcerated and undocumented individuals. Okay, so for non-residents who are eligible, non-residents who work 20 hours or more per week in Massachusetts, who pay applicable state taxes, and who pay any additional premiums established by the trust to cover non-residents. Also, non-residents requiring emergency treatment will be able to participate, but then the trust will recoup whatever expenses it can from their insurance or whoever's taking care of them in their state of residence. Okay, and for travel and visitors, emergency care for Massachusetts residents provided out of state will be reimbursed at prevailing rates. Non-emergency care for Massachusetts residents obtained out of state will be reimbursed according to rates set by the executive director. And visitors to Massachusetts will be billed for services received under the system. And it may be, this is in the bill, the executive director may require that a resident be transported back to Massachusetts when prolonged treatment of an emergency condition is necessary, if transportation is safe for the patient in light of the patient's medical condition. Okay, eligible practitioners and facilities. Eligible practitioners and facilities will include those providing any covered benefit to an eligible patient, so long as the practitioner or facility is licensed to operate in Massachusetts, does not accept payment from other sources for services provided by the trust, provides a signed agreement to not discriminate, to keep patient information confidential, and to not practice balance billing, and to provide the trust with all reasonable information needed to make payment decisions, meets state and federal guidelines on safe staffing, quality of care, and efficient use of funds for direct patient care, and meets whatever additional requirements are established by the trust. And in case you're not familiar, although I'm sure we're all familiar with what balance billing is when a provider bills a client for the difference between the provider's fee and the amount allowed. For example, under the system we currently have, what's paid by the insurance company, and then the rest of the bill gets sent to us. Balance billing will become a thing of the past. It will not be allowed under this system. Okay. And this was a note added in this version of the bill, the 2025 version of the bill. Since a hospital's purpose is to serve patients and not to enrich private shareholders, the Department of Public Health will no longer issue a license or renew a license for any hospital that is not a 501c3 nonprofit. And of course, this is related to the Stewart Hospital crisis of 2024. Okay, so what's covered under the trust? The trust will pay for all professional services provided by eligible practitioners and facilities to eligible participants needed to provide high-quality, medically necessary health care, increase the use of preventive and primary care, and integrate physical, mental, and behavioral health and substance abuse services. That's in general. And then I believe soon we get into a little bit more of the details. Okay. The next few screens covers everything that is covered as elaborated in the bill. Just briefly, labs, diagnostic testing. You could read through this if you want. Palliative care, dental care, acupuncture, physical therapy, screening, counseling, health education, rehab, physical, psychological, and other specialized therapies. Just wait a moment in case you want to see the other blood and blood products, dialysis, mental health, it's all in there. Here's more. Behavioral health services, including supportive residencies, substance abuse services, including supportive residencies, prenatal, perinatal, and maternity care, fertility and reproductive health entirely covered, long-term services and supports, including home health care, long-term care in institutional and community-based settings, and hospice care. Language interpretation, emergency and other necessary transportation, and then here, dental, vision care, including glasses, hearing, all prescription drugs, medical equipment, emerging technologies such as telehealth and telemedicine, and then treatment for long COVID is specifically mentioned in the bill. Oh, and you might notice, including glasses, excluding laser vision correction for cosmetic purposes. So medically necessary care, not cosmetic care. Okay. No deductibles, co-payments, co-insurance, or other cost sharing will be imposed on patients. And patients will have free choice of participating physicians and other clinicians, hospitals, inpatient facilities, and other healthcare providers. And a note on insurance companies will be prohibited from charging premiums to eligible participants for coverage of services covered by the trust. So basically in Massachusetts, likely that would be an industry that would go away. Okay, wraparound coverage. The trust will ensure that those eligible for federal programs such as Medicaid and Medicare will receive the same coverage as other Massachusetts residents under single payer by covering any gaps in coverage or cost sharing until negotiations with the federal government are complete. So if the single payer system gets put in place before those waivers have been negotiated by the executive director, then folks on Medicare and Medicaid don't have to worry that they're going to have less of a standard of care than everyone else in Massachusetts. Everyone will be covered. Okay, so how is this all going to be funded? First of all, there'll be an employer payroll tax of 7.5% on W-2 wages, exempting the first $20,000 of payroll per establishment. And then for establishments with 100 or more employees, there'll be an additional 0.5% payroll tax. Employee payroll tax of 2.5% on W-2 wages, exempting the first 20,000 of wages. 10% payroll tax on W-2 wages for the self-employed, again, exempting the first 20,000 of payroll. And a 10% tax on unearned income above 20,000. However, important to note that Social Security, pensions, SSI, SSDI, unemployment benefits, workman's compensation, sick pay, paid family and medical leave, and certain capital gains will not be taxed. With regards to the 2.5% employee payroll tax, employers may agree to pay all or part of the employee's payroll tax obligation. Could be collective bargaining or just a hiring incentive. Also, this is just a quick note because it's going to be mentioned in a moment. 6 months before the implementation of the trust, laws requiring health insurance carriers to maintain cash reserves for commercial stability will be repealed, and the executive director of the trust will collect the same amount that was held in reserves to be put into the trust as a stabilization fee. Okay, so how is this money going to be allocated? Well, 5% or less of the trust income annually will pay for preventive care, education, outreach, and public health risk reduction. 2% or less to supplement training of the healthcare workforce, and 2% of less to supplement other sources for training and retraining workers who are displaced as a result of the new system. 1% or less to supplement other sources for medical research and innovation. 1% or less to fund a reserve account in anticipation of demographic changes, inflation, epidemics, and extraordinary events that could impact healthcare costs. And importantly, the administrative costs of the trust within 2 years of full implementation will not exceed 5% annually. For comparison, administrative costs for private insurers in the US tend to range from between 12 to 20% of premium charges and include expenses like marketing, claims processing, customer service, and broker commissions. And Medicare operates at a 3% overhead. Okay, timetable for implementation of the trust. No later than 45 days after this legislation is enacted, the governor and attorney general will make initial appointments and coordinate with the secretary of the state to set the date for elections for the 8 elected trustees. And the first board meetings will take place within 10 days of the election of the trustees. John, I think I'm going to change that because I believe this is the part of the bill that was changed.
Yes,
there are
we just didn't catch this correct. We didn't correct this slide.
Yeah,
So,
these are going to, these are not elected trustees. These are 8 appointed trustees from the different regions of the state.
the governor's council.
The governor's council.
In the discussion, we can get into the constitutional issue that required us to go to appointed versus elected.
Right, so we'll fix this slide. Okay. In the first phase of the transition, the board will hire an executive director, review enabling legislation, establish a first-year budget, begin the process of federal waivers and agreements for Medicare, Medicaid, and other public programs, and set a time frame to launch the trust within a year of the first meeting of the board. The executive director will begin hiring staff, establishing infrastructure, and negotiating reimbursement lists. And practitioners will develop plans for transitioning to the trust. In the second phase of transition, infrastructure for the trust will be established, including the regional offices to provide public education, training healthcare practitioners and staff on processing bills, and introducing accounting regulations to employers for payment of payroll taxes. Private insurers will complete the transfer of cash reserves for the trust that was referred to a few slides back. Residents of the Commonwealth will each receive healthcare identification cards with an explanation of benefits and contact information. Oh, and there's our friend Bill. Let's get this guy to the finish line. So I'm going to stop there. Okay. Okay, so that is the bill in a nutshell. That's all of the pretty much all of the important parts of the legislation pulled out and distilled, I hope in a way that's kind of digestible. This slideshow, of course, is available to anyone. There's a link on Mass Care. Feel free to share it as it's useful to you, and see if there's any questions or discussion points.
There was one in the chat, and I put the answer quoting the bill. It was the question of how long the term is of the members of the board, and they're 5 years, but in the first the first 5 years, it's staggered, so that then going forward, the entire board doesn't turn over in any given year. So, Mary, I hope you that satisfies the answer you're looking for. Does anyone else want to, go off mute and just ask a question? Yeah, Mike.
Yeah, I'm new to this meeting. I'm a retired neurologist, just retired about 6 months ago after 48 years in practice, all of which has been private with various size groups. And one of the problems that physicians have is the administration of services, which have become onerous over the past 20 or 30 or 40 years. And we can see, those of us who think there should be something like a single payer service, that that a severe reduction in administrative burden, meaning how much time we have to fill out forms, how many people we have to hire to fill out forms, et cetera, would probably give you enough or more than enough financial stability to pull this thing off. Mm-hmm. Is this the place to ask a number of questions such as, how much is the system costing right now? How much will the new system cost? How much, or what are you going to do to reduce administrative burden throughout the system? You say that everything will be covered, but they have to be medically necessary. Who decides what's medically necessary? Is there going to be an administrative service or staff to impose its will on physicians? What happens if you want to have a service that's not covered? Can you have an insurance program such as available in Britain to have a gap insurance? You say that you want evidence-based medicine to be in effect throughout the entire system, which of course inhibits any new developments, because there will be no evidence for new developments. How do you work? How do you prepare for that, or how do you accommodate that? Let's see, what else do we have here?
These are fantastic questions, and I'm sure of interest to everyone who's here. So if you want to go back to the top, let's try to go through them.
Well, since this is recording and we can maybe write it down afterwards, and since I'm on a roll, let me write down these, or let me mention these questions, and we can go from there.
Start anywhere you want.
Can a practitioner practice in Massachusetts and not be part of this program?
The inability to be paid will incentivize every practitioner to join the program.
But if someone wants to have a concierge practice, can that person do it?
It seems like that's going to be a loophole, but we're not going to worry about it because we're going to be covering, 99.99%.
I noticed that the patients have free choice of practitioners.
Yeah.
Do the practitioners have free choice of patients?
Probably not. The intent is to solve the access problem. Right. And so we expect, keep in mind as we go through these, folks, that there will be some questions that while we'll give general answers, it's the actual administration of the trust that will decide what may be controversial questions, and including the negotiation of reimbursement rates. And then the governing body of that trust, in order to make the right decision, will be beholden to us. But I do want to at some point explain why they can't be elected. Some of them can't be elected anymore.
And just as a
keep going, Michael.
Just as a practical question, I noticed that there's a 10% tax on unearned income for high earners to fund this. Have you gamed to see how long it'll take to flush out all those high earners from Massachusetts who will no longer want to pay such a high rate, such as, say, a fellow makes $1 million a year in dividends. You're going to charge them $100,000 a year to support the
It's capital gains,
right,
not
right.
not in interest income or dividend income. It's capital
Well,
gains.
capital gains. Say
Oh,
that.
so you have to remember, capital gains is when you sell
Right.
the investment.
Suppose you sell your stock. Suppose you're in Cambridge and you have a startup company that's doing pretty well in the biomedical field, but you know that if you sell your stock to get rich, you're going to be spending 10% or giving 10% of the state on top of the 4% that you're already charging by legislation. So how long will it take to flush out those people from staying in Massachusetts?
Yeah, well, they've just got a surtax of 4% over
Right,
$1 million on income, and not capital gains, but income. Capital gains, by the way, has a
Right.
major.
I understand, but it's the
Well,
net effect is that it's going to cost them a lot of money. And how long do you expect to keep those people around?
Yeah, right now, I'll put in the chat the link to the economic analysis. And if you look at the slideshow that's there from Professor Friedman, he goes into that. We summarize it. There's an estimate that 98%, I think it is 98% of residents are going to save money under this deal. The 2%, if you think the 2% will leave the state, I think that's already been tested, because nobody has left the state because of the surtax on the multimillionaires, the fair share tax.
Yeah.
But that's a sociological experiment, and they're going to get a better deal on healthcare than they're getting from whatever insurance company they've got right now. They're going to get more coverage. But go back to some of the other questions, because you had some really practical questions there.
Dr. Sorrell, I don't know if this answers your question, but you mentioned that, and I'm just saying this as a non-medical person, you had said that if they have to be evidence-based practices, then that doesn't leave room for innovation. I did want to mention that 1% allocation of the trust is specifically for medical research and innovation. So they are building that into the bill.
Right, but
that helps.
Say over the course of my career, I've been interested in something which has not attracted much research data, but my patients get a whole lot better with these techniques.
There's going to be quite a lot of hiring of experts from some people who are already working in doctors and others who are already working in insurance companies in Massachusetts. They're going to want to stay here, and they're going to want to be hired by the trust. The expertise at that administrative expertise level is a lot of your answers. And so we really need to put together the movement to win this thing, to see what the regulations are going to be. But this particular workshop right now is to understand the bill, because then we turn around and we talk to people about how this is better for them, and to tell their reps and senators. That's another workshop, how we're going to lobby and win. In fact, we're going to do a conference on June 21. Go ahead and put a note on in your calendars. We're going to do a statewide conference on how to win the bill. In the meantime, let's see what the questions are about what the bill intends. For instance, there's a question in the chat about identifying income. Well, this is the Department of Revenue will be integral, and there's even the assumption, even though it can't be put in the bill, that the deduction, the $20,000 deduction, will be built into a tax. It'll be built into the employer tax rates. So their employers, and of course now most employers are using payroll services. The payroll services are given a tax chart, and and it's electronic. It's all formula, and that formula will be a DOR issued formula to assess the tax. So we're going to have a lot of activity at payroll. That goes to the other question of what about the Social Security tax? So, at payroll, our taxes are modeled on the Social Security and Medicare taxes, and they are payroll taxes. Not everybody pays them, but you pay them at payroll. So in the payroll taxation formula, you'll notice, and if you read the bill, there's nothing about eliminating Medicare. For those who are wondering, this is not a wholesale replacement of Medicare. What it is a relationship between Massachusetts and Medicare so that the Medicare gathers the tax from the paychecks and then gives it to Massachusetts. The bill, as Stephanie noted, has a wraparound clause which allows for Massachusetts not to receive Medicare and Medicaid money if necessary. Right now, Medicaid is a different setup. Medicare money, because maybe Uncle Sam wants to continue to pay the bills in Massachusetts, and we don't get that waiver. It's called a waiver. So we go either route. We either get a lump sum from Medicare and then we pay all the bills, our trust fund pays all the bills, or we let Medicare continue because they insist and we have no power to stop them. In which case, the state will not be a one-payer state, it will be a two-payer state. But what it also means is that the Medicare recipient, or Medicare enrollee, would be the proper term, is now guaranteed by the state that anything besides what Medicare pays will be paid by the trust fund. So that means you no longer have to pay a premium for Medicare A, B, if you go into Medicare B and Medicare Advantage, or C or D. Not A. A has for some people a small premium. B has a standard premium. Those premiums disappear because the trust fund will pay them. And then when you go into a premium-based system, you're expected to pay copays. Those copays will be paid by the trust. So that relationship to Medicare means that Medicare continues to operate in the state. And it's very similar to what we anticipate regarding the VA. The VA continues to operate in the state without being touched by this bill. And so does the American Indian Health Program, because those two are actually health services and they are not insurance per se. And Medicare and Medicaid are a version of insurance. So it's feasible. We know that we've already anticipated this with the VA. It's feasible to let Uncle Sam continue to operate its programs in Massachusetts and the trust fund just pay the rest.
Well, it's if I were a citizen wanting to advise my legislator on whether to vote for this bill or not, the first thing I want to know is how much is it going to cost me?
Yeah, okay. Please take follow the link.
Right.
And keep in mind that what happens if you're in a Medicare for all movement like this one, every state that's in it, especially California, New York, those are the leading states, you can't answer that question because you don't know what the trust fund is going to negotiate with the doctors and the hospitals. Right. And you also don't know whether or not your taxes, the way you've designed them, are going to be politicized and changed by the legislature when they finish the bill. We propose 4 new taxes, but that doesn't mean that's what the bill's how the taxes are going to work when the bill's finally voted on. The other thing is that we have an economist, Jerry Friedman. He's an expert. He consults to most of the state-based single-payer movements across the country. And he has designed an approach to economics that gives us a best guess at the answer. So what he does is he takes current spending in Massachusetts for everything. So in other words, we are not going to not spend where Massachusetts is spending on, say, echo cardiograms, we're not going to not spend. All the spending that's current is built into his first assumption. Then he itemizes waste, fraud, and profit, and he just takes them out of there. Then that's based on assumptions of what the amount of waste, fraud, and profit is in Massachusetts. That leaves you with a number, and you can follow the numbers on the webpage. That's about almost 40% of current spending. But we know that there are hospital deserts and primary care deserts and difficult access all across the state. So he then adds an assumption of about, I think it's $11 billion worth of expansion. That still saves us 30% of current spending. Still saves 30% of current spending based on the assumptions he has to make as an economist that we asked to give us a price, to give us an answer to your question.
Well, that seems intuitively obvious because European systems are 30% less for dispensing care, which is the equivalent of ours or even better.
We can't adopt any percentages in other countries, though. It has to be specific to Massachusetts spending.
Well, I understand, but that's the ballpark I've been working under for the past 30 years or thereabouts, is that with the reduction of the administrative costs, you can recoup another 25%. So when I will spend the next few hours or many hours reading through this information that you've directed me to. But if someone comes up to me in the street and says, I'm a guy that makes, I'm a part of a family of four, we make $120,000 a year. Can you tell me that I'm going to be spending less money on my medical care?
Yes, there's a way to do that with people. So you ask them, what's your income? What is 2.5% of your income?
Mm-hmm.
Now, go look at your bills, because that 2.5% is not just replacing your premiums.
Mm-hmm.
It's replacing your copays and deductibles.
Mm-hmm.
Go take a look at your healthcare bills. Try to figure out what that is as a percentage. Now, we do have a calculator on our website in the labor page. We have a calculator that tries to do that, but people are so different. So what Jerry, our economist, did is he did it at the level, the macro level of total income in Massachusetts, total spending by wage earners in Massachusetts. And he figured out that basically the rule of thumb is you're going to pay 50% less.
Just to add, John, it would be you take your gross salary and knock 20,000 off first, right? And then
yes, don't forget to knock the 20,000 off first.
I did this with my husband last night just for fun, and he was very surprised.
So at what level are you going to be paying the same amount either way?
Oh, I think Jerry said 2% of people are going to pay more.
Yeah.
Or some people are going to pay more. Very high income, very high income.
Such as?
You're going to have to take a look at his slideshow. He has a
you don't know
slide.
off the top of your head if that's 200,000 or 500.
The income level? No,
yeah.
it's definitely more than 200,000. You know, because the insurance plans are outrageously, the premium level is outrageously overpriced to begin with. So everyone's saving money just by going to a single payer.
I have a question.
Let me just answer Mary's really quickly, because Mary, unfortunately, the savings, the analysis that's on that webpage is from 2 years ago.
Oh.
Jerry is now battling cancer and has not been able to update his numbers. However, we're seeking a contractor that he will work with. He's somewhat able. He has extremely low energy. So we're looking for someone else to do the actual legwork, and we will have 2025 numbers soon, we hope. But in the meantime, that is what you're asking for. It's on the website.
Also, there were a couple questions from Jeff in the chat, just in case he wants to jump in.
What about mass state workers and retirees? Yes, GIC goes away. You want to follow up that question, Jeff?
Well,
Well, I mean, there's obviously a huge number of mass state workers. And there's an equally large group of mass state retirees, of which I'm one, even though I haven't worked for them for over 25 years. But I mean, everyone in that system when they reach Medicare age is required to go in there. The problem with Medicare, and I understand, I mean, the Medicare issues, and you kind of touched on some of this. Medicare, I mean, even Medicare does tax your SSN income and whatever else income you get. And that's how and then there could be an added premium to Medicare, which I presume this bill is not going to touch.
The only Medicare tax left in the state is on W-2 income.
Yeah, so but that includes your Social Security income.
No, well, you're saying that there's a Medicare tax on Social Security income.
Not a tax. You pay once you're in
Yeah,
Medicare.
well, no, you pay
That's
your
not
premiums out of
true.
your Social Security.
Premium,
You pay your Medicare premium
before I even see my
for B and C and D. You pay that out of your Social Security.
exactly, even if I'm not using it.
Yeah, yeah, right. But the point is, that's a premium system for a version of insurance.
But that's not going to change in this bill.
If you decide to continue in Medicare, this is an interesting dilemma for us who are in Medicare.
Mm-hmm.
We will be incentivized to just give up Medicare during the open season, abandon it. Uncle Sam won't let that. The waiver has to stipulate that we can abandon Medicare, get out of it, and when we move to another state, get back into Medicare. So the details of the Medicare waiver negotiations.
That's a big deal because
that's a big deal, especially when you're dealing with an adversary in the White House.
Exactly, because do you know that right now, if you do that, if you stop and you come back in, you're required to pay
it all back. There has to be a return to Medicare without a penalty. So all that negotiation is based on our strong point is that we're going to cover everybody cheaper. We're actually going to save Medicare money because in the long run, the Medicare coverage, these enrollees are going to be much more healthy. You know, the less healthy, yeah, that's the word, population are the seniors, and they're the ones that cost insurance plans the most. So by building in access from cradle to grave and also preventive care and all kinds of good things about healthcare, letting the doctors, be the ones who decide, you're going to have healthier seniors. Who knows if that argument will win with a Medicare administrator who just wants to control the outcome, or an administration that wants to destroy Medicare. So right now we have to go on the premise that we're optimists. If we win this thing, it's going to really benefit us, and it'll lead to a domino effect in the other states, so that Congress will pass a single payer bill that will remove the contradictions that exist when one state has a single payer and everybody else is under Medicare. Let me answer this question here about from Mary again about the online cost calculator. So there's the only data that goes into a cost calculator is the taxation rates in the current bill. So I don't know what anyone would have thought could be from 2002. So if you use the calculator.
Well, I was referring to the calculator like for the city.
Yeah, the municipal calculator.
Kimberly said that they were based on 2004 data. So we had a call that last Thursday evening. And so I was pretty surprised.
Mary, what I said is that we have a downloadable spreadsheet with every state, with every town and city based on the 2022 data provided by the DOR. I can put the link. You can do your current town or city's municipal calculations using more current data. That's all we had available to be able to do every city and town in a downloadable spreadsheet.
Yeah.
Okay, if
So
you would
when,
put that in, I would appreciate it.
yeah, and when I see, in other words, not 2022, but not 2002 in your chat, you meant 2022. 2022 is still pretty good data. The cities and towns in general are, they're still their budgets are still in the same ballpark as a couple of years ago. Actually, our database may be up to 2023, but the point is that now they are taking a gigantic hit. So are all the employers, and so are a lot of families' plans, and everybody's is being hit with double-digit inflation of premiums. And in a system like that, you know what it means? It means the savings are even bigger. So when we talk about a savings of it may be still the same percentage, 30%, but when you look at our page and you see that, let me look at it quickly, that the number, the budget is going to be $89 billion, and the savings is going to be, or expected, it's expected, is going to be about $37 billion. As premiums go up and we start saving on that money, the amount of the savings goes up. It's unfortunate that we're in that boat.
I put it in the chat. It is now the 2023. Now that we passed the new year, we were able to get the most recent data, which is 2023. And there's a downloadable spreadsheet. I put the link in the chat.
So we run out of questions? Because Michael, you asked a lot of questions that you skipped over. If you want to go back to them, we want to have a video. This is being recorded, and we want to have a video that other people could watch. And so if you've anticipated their question, it'd be good for you to get an answer tonight. Or anybody else. Well, then we can close the workshop. I really appreciate you coming. What we'd like to, let me give you the constitutional problem we ran up against. And then what we'd like, and I see that most of you are activists in this movement, we'd like you to make sure that your state senator and your state representative are co-sponsoring the bill. And if that means you need to confront them on lobby day, please sign up for lobby day. You can do that on the front page of our website. And then we'll take an evaluation of our progress in June, and we'll see what else we have to do. So let me just quickly tell you that for years now, this bill has had provision that 8 of the trustees would be elected from governor council districts. Everyone has always thought that to hold the trustees accountable, they needed some elected representatives. And then in the bill review process this year, someone said, it may have been Representative Sabadosa, because she's studied constitutional law. She just said, is that constitutional? So we consulted an expert on the Massachusetts Constitution. And we're going by his judgment that in order to have an elected position in a bill, statewide election, part of the statewide November elections, we would have to amend the Constitution. The amendments to the Constitution take at least 4 years, and they also they take a lot of work, and they have to be very popular to get them done, and they're rare. So we said, well, let's leave that to a battle for another day, and we'll have each of our already elected governor's counselors appoint somebody per district. So that's where that's at. there are a lot of people in our movement who are very familiar with this idea that there would be these elections. So we do have to tell them, sorry, we lost that for now. Any other questions come to mind? If not, thanks. And Michael, if you want to shoot over the ones that you didn't pose, or if you want to ask a few more, we get them on the video, and then we'll close it out.
I sent off a note. I got invited to be on an advisory panel for the foundational. I mean, the Massachusetts Department of Public Health is dealing with a lot of the questions that this health bill are dealing, have to get around, such as access and innovation, and trying to make sure that, basically moving to the concept that the public health system should be responsible for providing equal health care to all Massachusetts residents. So I think there's a potential ally there, and I think it'd be worth following up on.
That'd be great if you could put us in touch.
I can certainly try that. I don't know how politicized the Massachusetts Department of Health is, but when Stephanie went through the list of what the healthcare trust is going to try to create, this group, and this what's called the Foundational Public Health Service is already started that on a I don't know if you realize it, that Massachusetts is the only state in the entire nation that has the Board of Health. There's a state Board of Health, but then on a local point, there are 351 departments of public health that are separate and equal in the sense that they don't share anything. And that creates a potential big problem, because obviously you have small places, especially in the Berkshires and Western Mass, that don't do anything, and you have places like Boston that have all the power. And it's an interesting concept, but I'll try to follow up on that, because they're covering many of the same points. But I still think the concept of trying, and I just got the Board of Health in Pittsfield to vote a resolution in support of this healthcare bill. I should be having a meeting in the big first week in March with the mayor of Pittsfield. But I think as I've heard before in several of the discussions in this effort, is as long as the legislature is run by, has the power to decide which bills get an up or down vote, and the insurance companies have tremendous sway at that level, it's hard to believe that we're going to actually get an up or down vote on anything. But it would
we will grapple with that in the coming months, definitely.
Yeah.
Did you say?
I think trying to get the individual, if we got a majority of the towns and cities to vote a proposal to say that, especially now that their rates just zoomed up, and you show them that they'll save 10 to 15% of their entire city budget in one swell swoop, it would be a big deal.
We decided at our grassroots organizing committee, and then at the board level, to launch a committee for municipal activists to do what you're saying. And I hope you're on the list already. I know, because your work for that resolution. At some point, one of our board members is going to convene a meeting. It'll be an exciting project where, parallel to that, working with town officials, there's also some interest among a large number of Democratic town committees to run the calculator in their towns. We want to get that into a mass movement. Run the calculator. But did you say that this advisory council is up and running?
I don't know. I'll have to find out. I was
Okay.
involved over the summer and I spent a lot of time on it and talked to some of the organizers. It's coming out of the Department of Public Health.
If you could send whatever you learned to info@masscare.org,
Sure.
then
I can
Kimberly
send
and
what
I will get that and we can talk about it.
Yeah, and I'll try to find out what's actually happened.
Yeah.
To all but they've tried to reach out to every community in Massachusetts. And there, as I said, there's over 350 boards of health and several, and I'll try to find out what's going on, but there is a potential. When I talked to the staffer I talked to was very interested in what I had to say, and I filled up most of my comments with, if we had a mass care bill like is currently in this house, a lot of this stuff would be, would go a long way to solving a big public health problem.
Right. True story. I realized that I didn't introduce myself. Kimberly, I didn't give Kimberly a chance to introduce herself. Most of you I know her already, our executive director. I chair the board. There are people on the call that I don't know, but I think most of you have already gotten to you're here because you're interested in getting a little bit deeper knowledge about this bill, because you yourself will be maybe caught flat-footed like we are sometimes with an off-the-wall question, and we ought to know what we're going to say or who we're going to ask for the answer. Stephanie, I especially want to thank you for producing this, making it available. People can go and grab it and show it, and pretty soon the video will be up on that website right next to it. If you'd like to have the commentary, Stephanie was giving information that's not on the slides themselves, but if you get into the slideshow through the link, you'll be able to see some of the commentary that she was able to give us. And then there are some added information that came out during this Q&A. And then if you have other questions, just shoot them over. We are working with a technician, an IT expert, to create, using artificial intelligence, the ability for you to ask any question in natural language, and the AI will do the search for you of the answer. Of course, garbage in, garbage out. We got to make sure that the AI is trained on the right information. So look forward to that. And also I look forward to working with you on the actual nuts and bolts of getting this thing done. Thank you all.
Good night. Thank you.
John, are you going to stay on for a minute?
I could. Let me stop the recording though.